Good morning, everyone. Thank you for joining us for today's Knock Out Opioid Abuse webinar, Prescribing Opioids in the Time of COVID-19. Today's webinar is brought to you by the Partnership for Drugs in New Jersey and the Horizon Foundation for New Jersey. This webinar is being held in collaboration with the New Jersey Office of the Attorney General and its Office of the New Jersey Coordinator of Addiction Response and Enforcement Strategies, known as NJ Cares. And we thank them for their partnership, support, and collaboration on today's learning activity. Horizon Blue Cross Blue Shield of New Jersey, through its philanthropic arm, the Horizon Foundation for New Jersey, has been collaborating with PDFNJ on a 2-year Knockout Opioid Abuse initiative to address the opiate epidemic through community outreach, prescriber education, parent education, and statewide awareness campaigns. In light of the current pandemic, the initiative has expanded its offerings to include this webinar series to help continue the conversation about the opioid crisis as we all navigate through this difficult time. To deliver some opening remarks on behalf of Horizon Blue Cross Blue Shield of New Jersey, I would like to introduce Marlon Addison, Manager for Provider Partnerships. Marlon, good morning.
Good morning. Good morning. Thank you, Angela. I appreciate that. And good morning, everyone. It's my honor to join you this morning, and I would like to thank all of you, particularly for your interest and attendance today. These are very challenging times for everyone, and we greatly appreciate your dedication to continuing the discussion on how we can specifically knock out opioid abuse in New Jersey, especially during this critical time. I'm sure many of you are aware that due to COVID-19, the Partnership for Drug-Free New Jersey has had to cancel in-person town halls. But the Horizon Foundation has been working with the partnership to develop ways to continue this conversation and community engagement through social media, through the partnership's website, et cetera. The partnership team has quickly adapted by planning a series of webinars centered on how the pandemic will impact the opioid crisis. Today's webinar, Prescribing Opioids in the Time of COVID-19, is the 7th in this series. Horizon, through its philanthropic arm, the Horizon Foundation for New Jersey, is extremely proud of our collaboration with the Partnership for Drug-Free New Jersey to bring you to today's webinar through the Knock Out Opioid Abuse Initiative. This particular initiative is a part of our company-wide response to address and help end this public health crisis across our state and represents a large portion of the Foundation's $1.8 million we have invested to provide support for opioid prevention and education programs to help families and our members. In closing, I want to thank Special Agent Gibson, Acting Director Paul Rodriguez, and Dr. Nelson for presenting today, to New Jersey Cares for collaborating with us on this series, and to the Partnership for Drug-Free New Jersey team for putting this important webinar together. Together, we can make a positive difference in combating this epidemic. So thank you so much for partnering with us and for the time.
Thank you so much, Marlon, and thank you, of course, to the support of Horizon Blue Cross Blue Shield of New Jersey and the Horizon Foundation for helping all of us together address the opiate and addiction crisis in our state. So as Marlon mentioned, this webinar is the 7th in our series, but this is the 3rd of a 4-part mini-series that we are conducting in collaboration with the New Jersey Office of the Attorney General and NJ Cares to address the addiction crisis in our state and how it's been impacted by the COVID-19 pandemic. To kick us off today, I'm so pleased to welcome Assistant Attorney General Sharon Joyce, Director of NJ Cares. NJ Cares has been an invaluable leader in the state, and we're so pleased to collaborate with her and her office on this series. So welcome, Sharon, and thank you so much for joining us today.
Thank you, Angela. As Angela indicated, New Jersey Cares stands for Coordinated Addiction Responses and Enforcement Strategies. It is a dedicated unit within the Department of Law and Public Safety created by Attorney General Gurbir Grewal in February of 2018 to coordinate departmental efforts in addressing the opioid epidemic and create partnerships with other agencies and private groups similarly focused on implementing solutions. We are very excited to be part of this event today, joining with the Partnership for Drug-Free New Jersey to reach out to healthcare professionals, policymakers, law enforcement, and so many from the recovery community to discuss the current landscape for responsible opioid prescribing in these challenging times, and what we can all do to help reduce opioid overdose deaths and put those individuals suffering with substance use disorder on a path to recovery. I wanted to just share with you a couple of the things that New Jersey Cares has been active in. Prescribers and those who regulate their practices are vital participants in achieving this mission. New Jersey Cares has been proud to have played a role in offering robust prescriber education initiatives and working with professional licensing boards and the Division of Consumer Affairs, implementing regulations on opioid prescribing consistent with statutory changes. We've also played a role with regard to enhancing the prescription monitoring program so that practitioners can make the most informed decisions in the best interest of their patients and to track dispensing of opioids and halt diversion. We've also played a role with regard to expanding availability of naloxone throughout the state and increasing access to treatment and recovery services. In the area of prescriber education, we partnered with Rowan Osteopathic School to provide 6 modules of continuing education, 1 hour each, available in an enduring video on the best practices and recent statutory and regulatory requirements pertaining to opioid prescribing and patient care for individuals with substance use disorder, aimed at both prescribers and mental health professionals. Particular attention was given to the availability of telemedicine flexibilities in the era of COVID. Our recent enhancements to the PMP have improved New Jersey prescribers' ability to assess patients' risk for overdose by integrating PMP data into electronic medical records. These upgrades allow prescribers to make consideration of what the patient may be obtaining from other prescribers, part of their routine, everyday practice. With more sophisticated technology, prescribers can be alerted to the overprescribing of opioids and dangerous combinations of CDS and supplied with resources to which they can direct patients in need of treatment for substance use disorders. We are helping to increase naloxone availability. Last June, we worked with our Board of Pharmacy and the Department of Human Services to allow participating pharmacies throughout the state to distribute naloxone for free. During this one-day initiative, the program distributed naloxone to 16,000 individuals through 174 pharmacies throughout the state. We've also coordinated with the Department of Human Services to provide homeless shelters and community organizations with naloxone as needed during the pandemic. In addition, we collaborated with the Division of Consumer Affairs during COVID-19 to require the co-prescribing of naloxone when treating chronic pain patients on high doses of opioids or combinations of opioids and benzodiazepines, ensuring that patients at high risk of overdose discuss naloxone with their treating healthcare professionals and have access to that life-saving medication. Using state and federal grant funding, we are also increasing access to treatment and recovery by partnering with county prosecutors and local law enforcement in all 21 counties and connecting individuals arrested on drug charges with recovery specialists who can navigate them through treatment, or doing affirmative outreach to those at risk to assist with linkages to care. We are also planning to assemble emergency response teams consisting of police, recovery coaches, and EMTs available 24/7 to help individuals in crisis, connecting them to treatment and recovery. We maintain and update a list of treatment and training resources, including a list of pharmacies that have standing orders for naloxone, alongside important data on the New Jersey Cares website. The COVID-19 public health emergency has presented us all with great challenges in meeting the healthcare needs of individuals using illicit drugs, individuals at risk for overdose based on medical and mental health comorbidities, and those on medication-assisted treatment for substance use disorder. I'll let Director Rodriguez describe the efforts that the Division of Consumer Affairs has undertaken to meet these challenges, ensuring telemedicine can be utilized to the fullest extent possible and assuring that we have a robust healthcare, including mental health care, workforce to meet patient needs. While New Jersey Cares recognizes that the added challenges posed by COVID-19 in fighting the opioid epidemic, we look forward to continuing to address these challenges with innovative programs to engage individuals with substance use disorder in evidence-based treatment, enhanced prescriber education, and enforcement of appropriate regulation on opioid prescribing. I want to thank the partnership for allowing us to participate in this important series and look forward to hearing from all of the panelists this morning. Thank you. Thank you, Angela.
Thank you, Sharon. And I just want to mention that the continuing education opportunities that were just mentioned will be noted in the chat feature, as well as additional continuing education opportunities for prescribers that the Partnership for Drug Free New Jersey and Horizon have created that actually feature one of our panelists, Dr. Nelson. So we'll put that information in the chat feature if you're interested in checking those out. Just want to make one housekeeping note that for today's learning activity, there are no continuing education credits available. Just want to make that note for all of our attendees. But now, as we move forward, I'm so pleased we have such a varied and expert panel of featured speakers for today's webinar, all of which I've had the privilege to work with throughout the years in our shared goals of prevention and education through safer prescribing strategies, prescriber education, and addressing the opiate and addiction crisis in our state. And so I'm so pleased to introduce our panelists. We have Paul Rodriguez, Acting Director of the New Jersey Division of Consumer Affairs, Susan Gibson, Special Agent in Charge for the Drug Enforcement Administration, New Jersey Division, and Dr. Lewis Nelson, Chair of the Department of Emergency Medicine for Rutgers New Jersey Medical School. So I welcome all of our panelists. I thank you for participating with us today. And Director Rodriguez, I'm going to now turn things over to you so you can start us off this morning.
Thank you very much, Angela. Thank you, the Partnership for Drug Free New Jersey. Thank you, Mr. Addison, Horizon Foundation, and Sharon. Thank you again. I just got to say, if you hear all of the things that Sharon was talking about in her introduction, New Jersey Cares is involved with such a large number of projects. She's been doing a simply incredible job in coordinating those efforts from, practitioner side, from the treatment side, from the law enforcement side. It's really incredible. So thank you again for having me today. I will just start off by giving, many of you as practitioners are familiar with the Division of Consumer Affairs as your licensing body. Here at the Division of Consumer Affairs, we oversee 51 occupational and professional boards that collectively license around 750,000 licensees. Over 300,000 of those are healthcare practitioners. We've been at the forefront, along with NJ Cares, at combating the epidemic of opioid abuse. We have been, and we do that through a variety of means. So we do that through our professional boards. And next slide, please. And one more slide. Through our professional boards, through education, and as Sharon was mentioning, we've partnered to create a 6-part 1-hour session of continuing education regarding prescription opioids, and many of the licensing boards are requiring mandatory continuing education on prescription opioids. We do it through regulation, and I'll talk about some of those regulations now on limiting in the prescribing of opioids and the use of PMP, and we do it through those boards, the enforcement against indiscriminate prescribers. We also house the prescription monitoring program here within the division. I want to talk a little bit about how that could be a useful tool to you and some of the enhancements that we've done recently that Sharon touched on. We house Project Medicine Drop, which is a no questions asked collection of opioid medications for patients and consumers. We have the Drug Control Unit Prescription Blank Program to ensure the integrity of the prescription pads and blanks here in the state, as well as through our Office of Consumer Protection, litigation against opioid medications. Now, what I'd like to focus on a little bit today, and I'll say also that the division has been part of Governor Murphy's whole state response to the COVID-19 epidemic. And pandemic. We have been, part of our role here has been through expansions, facilitating expansions to telemedicine, expansions to the healthcare workforce, articulating some safety protocols. And I'll say that in all of those articulations, we continue to emphasize the value of telemedicine and the need to minimize person-to-person contact to protect you, your staff, and your entire patient population. And also through getting the word out. And so we do that to prescribers, to healthcare practitioners, and also to members of the public. And we do whenever, all of the changes that we've made and the extra tools that we try to provide here as a result of the current state of emergency are only as good as practitioners actually having that information. So events like this are incredibly important. We put out press releases. You can go to our website to get information. I'll just plug here a note. If you're not already receiving emails from us, please check in with your licensing board and make sure we have your current contact information. We're actively disseminating information to our licensees. So next slide, please. So first of all, with regard to, and next slide, with regard to telemedicine, I'll start off by saying, just big picture, we often get questions from practitioners, especially now who have not been practicing telemedicine, conducting telemedicine previously. All healthcare practitioners licensed in the state of New Jersey have been authorized to provide care through telemedicine since 2017. I will note here that we are generally agnostic as to whether care is provided in person or utilizing telemedicine. Standard of care always applies, and that includes using your clinical and professional judgment to determine whether telemedicine encounter is appropriate and whether you're able to, for the given circumstance. And all of the record keeping and prescribing requirements, the P&P requirements, all continue to apply whether you're in person or utilizing telemedicine. What I want to focus on, next slide please, is some of the temporary expansions that are in place right now during the current public health emergency. You'll see typically referred to it on the slides as the PHE. So some of these, for you to be aware of, is we've expanded the use, the allowable technology that can be used. For example, outside of this current public health emergency, the technology requirements are that you use HIPAA compliant software, understanding that we have many healthcare practitioners that we want to be able to provide care through and services through telehealth and telemedicine. We've expanded that in coordination and in accordance with guidance that has come out through U.S. Department of Health and Human Services to allow any type of platform that are typically available on cell phones, computers, where you can communicate directly with your patient in a private fashion. It does not have to be HIPAA compliant, but it can't be public facing. So for example, it is fine to use to either use audio only, so to call them on the phone. It is also fine to communicate with your patient via, if your phone has FaceTime or Zoom or Skype. All of those technologies are appropriate. Social media, be careful. There are one-on-one communications that can happen through social media, but obviously you would not want to communicate personal health information. It was not appropriate to use any social media communication that might be public facing. We've also relaxed the ability to establish a practitioner-patient relationship using telemedicine. Typically, you have to have an existing relationship and have to be able to review the records in advance. We did not want the availability of records to be a barrier to the provision of services, so you can establish that relationship using telemedicine. And we've also, the state has also waived the site of service requirements for Medicaid. Now, I'll note here, with regard to out-of-state providers, because we get a lot of questions about out-of-state, there is a statute that was passed, a law that was passed here in New Jersey that does allow, so typically you must have, and next slide please, typically you must have be licensed in New Jersey in order to provide telemedicine here. You have to be licensed in New Jersey if either the practitioner or the patient, or obviously both, are physically in New Jersey. There is now, during the current public health emergency, an exception if there's a pre-existing relationship with that patient. And this, to visualize this, imagine, we had tens of thousands of students, college students, for example, returning to New Jersey as their schools closed. Those relationships that they were seeing a provider in that state of their school, for example, would be able to continue to have that relationship with that provider, even if that provider was not licensed in New Jersey. In addition, if there's no pre-existing relationship, there's also an exception if you're solely providing care for COVID-19 care, so screening, testing, treatment for COVID-19, and that assumes, of course, that you're licensed in good standing in that other state and you're practicing within your scope. Now, with regard to, we've also recently made some changes and in response to the current public health emergency with regard to CDS prescribing. Next slide, please. And here, the existing requirements continue to stay in effect. So that's, you must take a thorough history, you must conduct a physical exam, and you must develop a treatment plan with identified goals with your patient. However, during the public health emergency, we've clarified that you can, and this is this is consistent with guidance from the DEA. You may utilize telemedicine to conduct that physical exam if consistent with the standard of care. And in your clinical determination, you're able to, that telemedicine encounter will be sufficient to conduct that physical examination. I'll note that that first visit must be audiovisual. As we say, real-time interactive audiovisual. It can't be phone only, although subsequent visits can be done via audio only if needed. Now, I will also note, and I mentioned out-of-state practitioners before, and there's one thing that I forgot to mention that is important here, is that for we have allowed and facilitated the ability for, we've always had an ability to get a reciprocity license, to get licensed, a New Jersey license if you're in good standing in another state. There we have facilitated that on an emergency temporary basis during the current public health emergency. What I'll note, the difference here is that if we are not requiring you to obtain a CDS registration in New Jersey, which, as you know, is required in order to prescribe CDS and controlled dangerous substances. But you do have to, so you are able to, if you have one of these emergency licenses, prescribe CDS in New Jersey. If you're authorized to prescribe CDS in your home state and you have a valid unrestricted DEA registration, all other New Jersey requirements continue to apply. So that's going to include these CDS requirements that I'm going over now. It's going to include the requirement to register with a PMP to do PMP lookups. Next slide, please. So, of course, in all circumstances, any services provided via telemedicine must be consistent with the standard of care. I think you've heard me say that like 10 times already. Prescriptions must be issued for a legitimate medical purpose, and you must be acting in accordance with the law. Next slide, please. So the 5-day rule continues in effect in the state of New Jersey during a public health emergency. That's for acute prescriptions, initial acute prescriptions of CDS2 or any opioids. For that, in accordance with the 5-day rule, you must discuss the risks and benefits of opioid treatment and alternatives. You must limit the prescription to no more than a 5-day supply of the lowest effective dose of an immediate release formulation. And if after those 5 days you gotta wait till the 4th day, you must determine after a consultation, which again may be conducted through telemedicine, that an additional supply is necessary and not present a risk of abuse or diversion. And you must tailor the supply to the patient's need. Now, when it comes to chronic pain, the 3-month, so the current restrictions still apply, and the current requirements, I should say. You must, every 3 months on a quarterly basis, reiterate the discussion of the risk of opioids with your patients. You must enter into a pain management agreement, and you must assess treatment goals and make a reasonable and periodic effort to taper or stop the prescribing. Now, again, these assessments may be conducted through telemedicine now during the current state of emergency. And under the same rationale and the same logic, next slide, please, we've also extended that to the authorization for medical cannabis. I will note that the two-way interactive video communication is required for the authorization of cannabis if you're going to be utilizing telemedicine. Next slide, please. Oh, yes, this is perfect. So what I wanted to, another change that we've made in response to the current public health emergency is we have stepped up we have moved forward in time. If you can go back to the co-prescribing slide. We have moved forward in time the requirement that, and so it's now in effect a requirement that prescribers must, and Sharon mentioned this before, must prescribe, co-prescribe naloxone, an opioid antidote, when in certain circumstances. And I'll note that this is consistent with a rule promulgated by the Board of Medical Examiners. It's also a rule that was proposed by the boards of dentistry, nursing, and optometry. We've just made this come into effect sooner during the current state of emergency as a result of the anticipated and unfortunately realized increase in accidental opioid deaths that's happening during the current state of emergency. Unfortunately, we've seen as a result of a confluence of factors between isolation, depression, anxiety, lack of the ability to have as much social support and structure, we have been seeing an increase in accidental opioid deaths. So we thought it was important now that patients have access to naloxone and it's required right now if a patient has one or more prescriptions totaling 90 MME or more each day, or is concurrently obtaining an opioid and a benzodiazepine. Now, there are a number of exceptions that are noted here. So at the end of the day, I will say we've made several expansions to increase the ability of prescribers such as yourselves to access telehealth. We encourage you to utilize telehealth consistent with the standard of care to the greatest extent possible. And if you have any questions, we have an FAQ on our website. We're updating it regularly. We anticipate some further updates shortly. So we recommend that you continue to check our website regularly. Well, what I focused on up to now has been some of the expansions and the changes during the public health emergency that are temporary in nature. I do want to flag for you the New Jersey PMP and some of the enhancements that we hope will be particularly useful right now. So I will say, so first of all, you all know if you have a CDS registration, if you're prescribing controlled dangerous substances in this state, you're required to register with PMP. And you're also, by law, required to check the PMP and look up your patient the first time you prescribe a CDS2 or opioid for acute or chronic pain, or Schedule 3 or 4 benzodiazepine. You're required to look up quarterly, that is every 3 months thereafter, that you're continuing to prescribe those medications, and any time a patient appears to is exhibiting drug-seeking behavior. But those requirements aside, the PMP is an excellent, and we hear this from prescribers all the time, an excellent diagnostic tool. We are continuing to add additional enhancements to make it more useful to you and for the benefit of your patients. And I just wanted to highlight a few of those changes right now. In the interest of time, the slides are, and you can move forward in the slides, and I'm sorry for the formatting change here when we talk about the PMP, but the slides have some interesting data. What I'll say about the data and the trends, you'll know a year-over-year steady decline in opioid dispensations. We've noticed a temporary dip while many offices, healthcare practitioners were closed and people were staying home, but there seems to be a reversion to the mean, going back to the expected, anticipated drop in opioid dispensations. I won't linger on the data, but these slides will be made available later on. They'll be available online. You can take a look at this. What I'll note are some of the PMP enhancements that we hope will be particularly useful to you right now. So one of the things that we've done is we have created, for one thing, we've expanded access to the PMP to substance abuse patients to So we have, for mental health practitioners, providing treatment for substance abuse patients at residential or outpatient substance abuse treatment centers licensed by DOH. We've also created a NARPS Care platform, which will allow users to more easily identify, prevent, and manage substance use disorder and detect potential cases of misuse. If you can go forward just a little bit, you'll see there's a visual of this. It's a color-coded interactive timeline that you can see, so you can see your patient's medication history. We've also created a communications module so you can so prescribers and pharmacists can communicate directly with one another. There's also we're also connecting, this is one of the things that we've heard from providers, is that they've wanted to know how they can contact, how they can find out if they want to direct their patient to addiction treatment centers. Right now, directly from the PMP, you can access a list of addiction treatment providers near your patients. And in addition, we've provided clinical alerts. And we've had great feedback on this. These are unsolicited notifications. So when you search for your patient, a little alert will pop up that will say, for example, when your patient meets or exceeds some potentially harmful thresholds. Again, the PMP is just another tool. It's another set of information that you may have at your disposal. So it will flag for you. There's multiple prescribers, multiple pharmacies that your patient may be seeing. They've been seeing, receiving high dose of opioid therapies for a long time. They're getting opioids and benzodiazepines concomitantly. Again, maybe not from you, but by different prescribers all at once. This is just incredibly useful information, and we're constantly making these updates and enhancements for your benefit. And you can see on some of the slides, you can see what some of this will look like for you. And I just want to reiterate something that Sharon mentioned before, also to make the PMP more useful to prescribers, we've allowed for the integration of the PMP directly into electronic health records and electronic medical records. And you'll see from the penultimate slide here, you can see a chart that shows how much more the PMP is being utilized and how many searches we're seeing, because it's right at the fingertips of practitioners. You can go in your health records and you can see and access the PMP right there from a single login. So with that, I know I've gone over a lot. I'm significantly past my time. I apologize. I will stay on for questions and answers. Again, this presentation is going to be available online afterwards. And here is a number of resources. I recommend that you go again to our website to get more information and to get up-to-date information, and make sure that your contact information is correct with us so that we can communicate directly with you. Thank you very much.
Thank you so much, Director. And yes, as you mentioned, this presentation will be available. A recording of this presentation will be available. You'll be sent a link to view it, and also it'll be available on the website knockoutopiatabuse.drugfreenj.org starting tomorrow. We may, as Director mentioned, run over time. We're going to just continue because I think this is really important information that we're sharing today. So just wanted to let everyone know, all of our attendees, thank you so much. And if you need to end with us at noon, we'll continue, and then you can check out the recording after. But thank you so much again, Director. I think that information that you provided was so important and gave a great perspective. And now for our next panelist, I am so pleased to welcome Special Agent in Charge of the New Jersey Drug Enforcement Administration, Susan Gibson. Good morning.
Good morning, everybody, and thank you so much for having me today. I truly appreciate the opportunity to discuss such an important topic. DEA has been instrumental in dealing with the COVID crisis and trying to help our partners navigate through this crazy time that we're facing. The mission of the diversion control portion of my division, which is overseeing pharmaceuticals and the closed system of distribution, it has been a very big component about trying to figure out how to navigate through this crisis and allowing people to to explore different means to getting the right medication to the people who need it. We work closely with our partners, FEMA, HHS, ONDCP, and SAMHSA. We primarily focus on the closed system of distribution, which basically tracks the raw material to the ultimate user. We keep track of that raw material up until when the person who receives that prescription. That is our purpose with DEA and the Diversion Control Division. Next slide, please. Next slide, please. Regarding the DEA's response to the pandemic, next slide, please. On January 31st, 2020, due to the outbreak of COVID-19 in the United States, HHS declared a nationwide public health emergency. The World Health Organization on March 11th declared that the global COVID-19 outbreak constitutes a pandemic. Next slide, please. Due to the global pandemic, the exemption of telemedicine was enacted by Secretary Azar and HHS, which simply put, took away our one in-person mandatory medical evaluation, which was required prior to the COVID-19. We took away that mandatory requirement. However, we still have to require that it's in the usual course of his professional practice, his or her the professional practice through the medical community, and that the telemedicine communication is conducted using audio-visual, real-time, two-way interactive communication systems. And also the practitioner is acting in accordance with applicable federal and state laws. But the main takeaway from this is that we removed the in-person medical evaluation during the pandemic and the national emergency. Next slide, please. Regarding the issuance of oral Schedule II prescriptions, prior to the pandemic, the prescriptions had to be faxed or sent electronically before the prescription was dispensed. We actually alleviated this immediate concern, and we allow the practitioners to have 15 days to provide a written prescription to the pharmacist. And if that's not possible, the practitioner can fax, take a photograph, or scan the written prescription to the pharmacy in place of the paper prescription. So we made it a little bit more convenient to get the prescription to the pharmacy and allow some leeway for the practitioner to get that prescription to the pharmacy. Next slide, please. Regarding quotas, in the beginning of the COVID emergency, we allowed manufacturers, bulk manufacturers, to maintain more than the 65% of inventory that is usually allowed. This was increased because we did not want any disruptions of the manufacturing needed to maintain the medication flowing out to those who need it. So simply put, the quotas in the United States, bulk inventory, we were able to alleviate that 65% quota and allowed them to have more inventory in place for 65%. However, the usual quotas that a manufacturer is given, that is not exempted, and they still have to go through the standard process for obtaining a quota for their manufacturing ability. So that has not been changed. It's just the inventory. Next slide, please. Regarding the national drug supply, DEA works closely with its partners to make sure that any possible shortages are identified as early as we can identify them, to make sure that there's no disruptions regarding the distribution of prescribed medication. We work with the FDA very closely, FEMA, and others to make sure that the demands for the drug supply is not interrupted in any way, shape, or form. Next slide, please. Regarding narcotic treatment programs, it is very important for DEA to make sure that those that are dealing with addiction get the proper medical assisted treatment that they need to combat their addiction. We simply put made it a little bit more easier for the delivery of the MAT medication, whereas before it was only to be delivered by licensed practitioners or a written authorization of a designated practitioner to deliver said product. However, we are now allowing, we're expanding that to a narcotic treatment professional staff member, law enforcement officer, or National Guard personnel. So we alleviated the burden of making sure that it was only a licensed practitioner or an authorized person by the NTP. Next slide, please. During the pandemic, we worked closely with the Department of Health and other hospitals who were affiliated with setting up the temporary hospital locations. The process of obtaining the proper DEA registrations for these field hospitals was accomplished in an expedited time frame. The hospitals were located at the Secaucus Field Medical Station and the Meadowlands Expo Center, the Edison Field Medical Station at the Edison Convention Center, and the Atlantic City Field Medical Station at the Atlantic City Expo Center. We expedited all this. We got their medical registrations up and running in a very, very short period of time because it's a requirement for the registrations to be associated with the exact location as to where those medicines will be dispensed. So we work closely with DEA headquarters, with the hospital components, and we got it done in a very, very short period of time. Next slide, please. The COVID impact on the opioid epidemic. Next slide, please. Treatment and health, mental health implications. We had a real concern about the inability to access or continue with in-person treatment recovery support. The issuance of MAT goes hand in hand with therapy and meeting with people in the arena of whether it's a group setting or individual setting for counseling. When those two components work together, that's when MAT is really truly successful. So we ran into a problem that people that were in MAT may not have had the ability to engage with telehealth options, and that the telehealth options were not able to work for that person. So the disruption of the medical assistance treatment arenas were a big concern for us. There was also inability for some to access Narcan or fentanyl testing strips. And that was a big concern because of the fentanyl emergence. And then also due to social distancing, they may not have had a buddy when they were using, and the overdose was not addressed immediately. So therefore, we did see a small spike in overdoses in May. March, there was 253 people that overdosed in this state. April, there was 241. May, we saw the spike to 309. In June, it came back down to 256. So prior to COVID, we believe that people that utilize drugs on a regular basis were with others who may have been utilizing the drugs with them. Being that they were confined to their home, and if their family members were unaware of their issues, they could have been overdosing and no one was there to at least get them the help that they need. So we can think that that was a reason for the overdose spike in May, is because, people were dealing with their addictions in private, and they didn't have that system around them that usually got them the help that they needed, or were able to call 911. And a lot of times people that are in the throes of addiction also hide their addiction from their immediate family and friends. So this is what we kind of thought was the spike in May, up to 309. Next slide, please. Treatment and mental health implications. Increased mental health issues due to COVID-19, including overall emotional response to pandemic, isolation, and other factors like job loss and homelessness. People got depressed during COVID-19, and that could have explained the spike also. Also to potential drug channels that were disrupted because of COVID-19. They were not able to get their regular products, and they went to other avenues to obtain products that may have contained fentanyl and weren't exactly what they were used to purchasing or using. Again, we dealt with, and I think the next slide is going to handle that, we dealt with a lot of pharmaceuticals that are labeled as, let's say, Percocet, Oxycontin, all that on the street, but really are flat out fentanyl. And then the amount of fentanyl utilized in that product, it could be at a level that could cause an immediate overdose / death. So people weren't able to get to their usual products that they utilized, and they were seeking new avenues to obtain their highs. Also, decrease in seeking medical assistance for pain management or other medical care out of fear of contacting COVID-19. It forced some people to go to the street or different avenues again to get what they need to accomplish their high. And again, the big concern is that they were going to the street, getting the fake oxys, the fake Percocets out there, and they were overdosing. And then this is an interesting one. People that are using opiates on a regular basis are at an increased risk of dying from an overdose when potentially positive with COVID-19 due to the impact on lung capacity and oxygen levels. Opiates are depressants. So COVID-19, being that it has a direct effect on lungs and your breathing ability, those two working with one another really is a huge concern. So we did see that. Next slide, please. And again, this is touching on the false marketing of drugs. These drug trafficking organizations are making these pills look as authentic as you can possibly get due to the extensive pill making machines that they have and that they get into this country. Again, most of these drugs and most of these fake pills are fentanyl. So again, the wrong amount of fentanyl is deadly. You don't even have to be in the throes of addiction to take just the wrong pill and you could lose your life. And also fentanyl, we have to make sure that people understand fentanyl is extremely more potent than a lot of other products that are out there. The increased euphoria experienced by taking fentanyl or methamphetamine can lead the user seeking more of the drug, which can increase chances of overdose and or addiction. So they're extremely powerful. Next slide, please. DEA did notice effects from the border being closed. It really hampered the drug trafficking organizations' ease of moving product into the United States and also moving money out of the United States. It's created a backlog of US-bound drug shipments as well as a backlog of drug proceeds in the US bound for Mexico. Mexican organizations continue to use underground tunnels to smuggle illegal narcotics into the United States. Drug organizations in Mexico are also experiencing difficulties in obtaining precursor chemicals from China to produce the fentanyl and methamphetamine, as some is held at the Mexican ports. We have mass super labs in Mexico that are able to manufacture large amounts of fentanyl, large amounts of methamphetamine. To get that into the United States has been problematic. Next slide, please. More impacts that we have because of the closing of the southwest border is because of non-essential travel has been limited. International domestic travel restrictions are there. There's increased police and military presence, flight cancellations, stay-at-home orders, and curfews. Basically, because of COVID-19, it made drug traffickers and their crossing the borders a lot more difficult, both in and out of the United States. Next slide, please. Money laundering. As the drugs are having a hard time coming into the United States, they can't get the money outside of the United States. So moving actual bulk currency has been a problem to get it out of the country. They're having a hard time actually moving the product in the beginning because of the fear of COVID-19, the stay-at-home orders, etc. Also, we have noticed the amount and volume of money pickups have changed. When we work in an undercover capacity, What had usually been smaller amounts are now larger amounts because they have so much that they just need to get rid of. Of course, banks that are closed and are limited, that has a lot to do with the movement of money. And then what we've also noticed is definitely because of people losing their jobs and losing their income during COVID, we've seen a lot more of the bartering system that has happened, where they utilize guns, jewelry, anything that they can get their hands on, even if it's stolen or if it's their own, to barter for drugs. So we have seen that too. Next slide, please. And one thing that I am beyond proud of the New Jersey Division, even in the very beginning of COVID-19, when no one really knew what was going on, the women and men of DEA New Jersey were out there still doing their job. And our stats through COVID-19 are pretty amazing. So just during the national emergency, since March 18, we have seized more than 6 million in assets, 54 kilograms of cocaine, 39 kilograms of heroin. We've arrested 108 individuals for drug trafficking. We've initiated close to 70 new criminal investigations and close to 80 new diversion investigations. So we haven't let up. In addition, I'm going to say about a month and a half ago, we put diversion back to an alternating work schedule where I'm still able to do our on-site inspections of our registrants. I have 55,000 registrants in this state, and we are getting those done. But the men and women of DEA, we didn't stop. We kept on going, and I am beyond proud of what they're doing. We had to change some of our normal standard operating procedure a little bit, obviously. We've had a little bit of an uptick on the people that we have arrested recently, and we find out after the fact that they're positive. But the use of masks that we have employed as far as putting them on the person that we have arrested, and also with my people using masks, have been very successful, that I haven't had any positives stemming from an arrest at this time. So we're continuing with our mission. I'm proud of what they're doing, and we're here to make sure that New Jersey gets the medication that they need in a safe and timely manner, and at the same time go after those that try to violate the Controlled Substance Act. And thank you very much for your time, and I think I made up some time, so we should be back on schedule. All right. Thank you, Angela.
Thank you so much, and thanks for that information. I was unaware myself of how much DEA was doing during this time, so thank you for all of the efforts and for moving things along so quickly. So as I mentioned, I know that we're at the end of our scheduled time. We're going to continue. I know we still have over half of our registrants still on with us, so we're going to continue on. I'm going to now move to our next panelist. We have great perspective coming from Dr. Lewis Nelson. Dr. Nelson?
Thank you, Angela. And I do want to thank you and PDFNJ and the other organizations and agencies that are involved with this symposium. I think it's been already very informative to me as well. Just by way of introduction, I'm Lewis Nelson. I'm the chair of emergency medicine at Rutgers, New Jersey Medical School in Newark, and I'm the chief of the ED at University Hospital. I'm also a medical toxicologist, and I'm a senior consultant at the New Jersey Poison Center. So I come at this from a bunch of different approaches, of course, and I'm also board certified in addiction medicine and work here at Rutgers in both inpatient and outpatient management of patients with substance abuse and withdrawal. So I'm both a prescriber of opioids as a clinician in the emergency department for both acute and chronic pain, and I'm also fairly engaged in the management of substance use disorders. And I am very appreciative of all the efforts that the state and federal government have put into sort of addressing many of these issues that we face on both sides of the coin as we try to move through this pandemic. Next slide, please. And I will try to keep my comments brief because I'd like to get to the Q&A, and I see there's a lot of questions already in the chat, and obviously we will not address all of them, but I'll provide my contact information at the end if anyone wants to reach me directly. We really are facing in this country 3 inextricably linked epidemics. One of chronic pain, which unfortunately has been linked to high levels of opioid use. One of prescription opioid use, misuse, and overdose. And then, of course, the relatively new, less than a decade old, real problem with illicit opioids. Obviously, heroin's been around for decades, but the illicits, fentanyl, et cetera, have really changed the whole specter of this new and kind of third arm of the opioid epidemic. Next slide. Just some quick data to show you that we know that the rate of opioid related adverse consequences has been rising. I mean, it's clear it's been going on for a long time. We've seen some good news, perhaps, in some of the prescription opioid related fatalities, although it's easily been eclipsed by the amount of illicit opioid related fatalities. And here's just a quick analysis done by looking at some of the data from ONDCP, which is the White House's Office of National Drug Control Policy. They have an overdose detection program that will show you, and it sort of aligns with what the special agents had said in terms of the increasing rate of opioid overdose, which if you go to the next slide, I can show you in RED here. We've not really seen specifically an increase in the risk or the rate of opioid overdose. And I just want to frame that in a couple of different ways, because clearly there's a lot of competing influences on who's overdosing and how you define overdose. Are people overdosing and not coming to the ED? Are they overdosing and dying? And of course, fatality rate data does take a little bit of time to analyze and put out. And it's going to be even more complicated now, just because of the way, given the vast number of decedents that the medical examiner system has to face, whether or not we're going to really get the in-depth analysis of all these deaths to really understand the rate of opioid-related fatalities that we've seen over the past several months. So again, this is going to be very sort of squishy data. But again, these competing influences really do impact what we see in the emergency department. To frame the bottom graph, you can compare last year's visits and this year's visits, but remember that during the period of time that we're talking about, of say mid-March to mid-May, our ED volume was down by close to 50%. So even though the numbers of overdose visits stayed the same, for opioids, the overall visit rate was cut in half, which in a sense you can argue doubled the rate of visits that we were having. We know that there has been some explanation for this. I mean, part of it is that the availability of drugs on the street has, of course, become more limited for reasons already mentioned by DEA in terms of the borders, and we've seen some of the prescribing data from Mr. Rodriguez come out showing that the number of opioids that have been dispensed through pharmacies has fallen. But we also know that the amount of buprenorphine on the street seems to have increased, which is, in a harm reduction model, actually a good thing. I understand the word diversion is a dirty word, but at some level, the increased availability, which is associated with a falling price of buprenorphine on the street, might have mitigated some of the risk of overdose in this population. It's really unclear, honestly, about what all this means. This is sort of word on the street sort of data, and not something I could point to a really nice study to show you has been, in fact, true. If you go to the next slide, the availability of naloxone is something that many EDs have focused on, and many prescribers in general. And before COVID, there were a lot of nice mechanisms burgeoning in order to allow us to get naloxone to the patients who need the most. Unfortunately, it does require a pharmacy visit. In many cases, it requires somebody to pay for it. And particularly if you're uninsured, that's an out-of-pocket expense that many of our patients who have substance use disorders either can't afford or won't afford. You know, given $120 to buy an intranasal naloxone kit versus, you know, buy additional substances becomes a bit of a quagmire, I imagine. But we did give this out from RED. Our rate of dispensing of naloxone from ED went up. So I think there's a win there. Whether it's one of the reasons we weren't seeing more overdoses in the ED is certainly possible. We also know that EMS was overwhelmed and couldn't transport patients. So again, we're going to have to wait probably until the full data comes out and we have a big picture. Next slide, please. You've heard a lot about telemedicine already, and I think many of the people on this call that practice clinically probably have been involved with telemedicine in one way or the other. Many of you have probably even been patients on the other end of the telemedicine visit. We know that it's been a lifesaver for patients in pain and patients with substance use disorder. Next slide. Or groups such as this multidisciplinary group that came out with a paper just a few weeks ago, sort of trying to frame the issues about how to manage patients in pain. This is largely a chronic pain population. They sort of put a frame around whether or not patients needed to be urgently seen or emergently seen, and whether those visits were required in person or would be sufficiently managed through a telemedicine visit. And you can see the second line down really looks at those requiring opioid initiation or escalation and dosing. Now, this is a national effort, which doesn't necessarily comport with the state's guidances. Next slide. But I would remind everybody that one of the major things that has made our ability to practice medicine much easier is e-prescribing. No longer do patients have to come pick up prescriptions. We were always able to call them in, but this certainly takes away any of the need to mail in a prescription, which I think everybody recognizes is a daunting task in some cases and probably not done very well. Next slide. I'm not going to review again the changes in MAT use because you've already heard a lot about that, but there have been a few other changes that have not really been discussed widely, such as the general approach to using urine drug testing in order to screen for whether or not somebody's both using the substance they're supposed to be taking, which is buprenorphine, or using illicit or other substances they're not supposed to be using. So some of the changes around that, because of the difficulty in doing it, have changed the way that we practice addiction medicine to some extent. Next slide. One of the big changes that has really occurred is our comfort level with doing things like home induction. I mean, we've mostly used buprenorphine in our practices. The opioid treatment programs are sort of a life unto themselves, and most of us don't access those other than send patients there. But for those of us that practice in more of a conventional clinical setting, home inductions really become a big issue. I mean, many of us were always uncomfortable giving patients buprenorphine and say, when you go into withdrawal, start the drug, and rather we'd keep them around and wait till they were ready to do it. I think this has really become something we're able to do. And the 72-hour rule, allowing people to come back to the ED or to their provider to get the medication while they're waiting for a prescription to be filled or while they're waiting to find a provider that can write a prescription depending on where they work, has also been something we've been able to implement. And of course, the idea of a warm handoff, which has been growing, the idea that we're going to start you on a medication and then we're going to hand you off to a provider that's going to give you long-term care, has also been very helpful. Next slide. In our practice here, we've started people on buprenorphine in the emergency department, given them a prescription to go home with. And then again, on the top, we've given them a warm handoff. And on the bottom, what we've been able to do in many hospitals and many of the larger practices around the state are able to provide much more of a care navigation program. Next slide. And what that really means is taking somebody, and this is our care navigator program here at University Hospital, we're able to take a person who comes in after an overdose or has another reason to need long-term opioid addiction management care and connect them up to a person. In this case, somebody who's had lived experience with substance use is able to connect with them and provide a much more of a direct connection and follow-up through long-term care. Now, of course, this has been interrupted, like all of our settings have been, by COVID, and much of this until very recently has been done on a telehealth platform. But it does still provide a nice link and a reminder that people have to follow up with their providers and stay with care and do all of the other wraparounds that go along with long-term success in recovery. That's it for me. Next slide. This is my contact information. On the next slide, if you'd like to reach out to me, and hopefully we have a few minutes left for some questions, Angela. Thank you, everybody.
Thanks so much. Thanks for that information. And we do have some time for questions. I know you did speak about telehealth and the impact that has made. And I was wondering if you could just speak more to that, because I know that has come up in a number of our other trainings as well, about the pros and the cons. So could you talk about that a little bit more, just in terms of opioid prescribing, but also MAT prescribing?
Sure. telehealth is what it is. I mean, it's not in-person care. It misses out on many of the important features you get when you see somebody usually in person. The little subtle changes in things and the findings you can't see in the person when you're only looking at their face. But it does provide the ability to do what's probably most important when we're dealing with opioid use disorder, which is give them buprenorphine or methadone, as the case may be, or whatever other sorts of counseling you might be able to provide. The fact is that what you miss out on is a lot of the group dynamic, the individual provider dynamic that you get, again, on an in-person visit. But you do get a good percentage of the way there with the ability to prescribe the medications. And all that you've heard from the prior speakers was really around the ability to provide those medications. The ability to start somebody on buprenorphine without an in-person visit is very important. And, the AV component is generally pretty non-restrictive. We have the ability in the emergency department to start them on that, and then their subsequent visits could be done either by telephone or by AV. But of course, the population often is a little bit AV challenged in order to be able to get to their appointments. But the telehealth platform has been a lifesaver. If it were up to me, I would prefer to go back to in-person visits. We could do urine drug testing if we were able to do that. And again, able to provide other services that we can't do very well through a teleplatform. But as I pointed out, our care navigators are on a teleplatform as well and able to provide that sort of assistance. There's really no true limitation on prescribing. I mean, we would normally e-prescribe if we could, or we'd give them a prescription to bring to the pharmacy. They seem to be able to get the medications. That doesn't seem to be a major hurdle, at least in the population I deal with. Others might have different perspectives on that.
Oh, great. Thanks. I think we have a question just asking you to expand on what you just mentioned on the urine drug testing, and if while doing telemedicine, would you recommend sending the patient to a lab such as LabCorp or Quest in order to do a urine drug testing, and any recommendations on navigating those challenges?
Well, the only issue I could say about urine drug testing you have to be very careful of is that it's done in an appropriate manner. Just dropping off a urine at a counter in a lab isn't really going to be adequate because there's just too many workarounds to showing either a clean or an appropriately a urine with an appropriate amount of buprenorphine in it. And really those are the two reasons. So I know the word clean and dirty is a bit pejorative, but the idea being that if you're on buprenorphine or whatever, you shouldn't be using heroin or cocaine or cannabis, etc. So we often look in the urine to see if they are. Now, in most cases, those people don't have any negative consequences other than additional counseling, but sometimes that could lead to some long-term interruption of treatment depending on what's going on. But much more importantly is that people are actually taking their buprenorphine. And again, if I were them and I knew all I had to do was dip a little buprenorphine into the urine and send it in, I would be able to do that. Now, that's not something you can do because we're way more advanced than that, but that doesn't mean that we could take this too lightly. So it's actually a bit more complicated than just sending to a lab, unless the lab is set up to do urine drug collection and testing properly. And that's what clinics do much better. And we're really set up to do that. But there are definitely places that are able to do it. So be careful who you send your patient to, and that they're able to collect the urine there and monitor. They have to check the temperature and the dilution and a whole bunch of other things to make sure that it's being done properly.
All right, great. We'll give you a minute to catch your breath and go over to Director Rodriguez. Regarding the co-prescribing order, do you anticipate this emergency regulation being reviewed by the medical board or adopted permanently in the future?
Well, as I mentioned before, our emergency order essentially moves the medical board, the implementation date of the medical board's rule early into the future and into the current. But the medical board has already promulgated the rule to require the continued co-prescribing.
Actually, they proposed it and it's awaiting adoption, at which time it would be permanent.
Exactly.
For the
Thank you for correct in terms of timing. But yes, the medical board has already proposed the rule.
And the 4 other boards have voted on it, but it's yet to appear in the New Jersey Register as a proposal. But we expect it to in the future.
All right, great. Thanks. Thanks for that. And I think, Dr. Nelson, I think we're just going to bounce back to you about Suboxone, and should it be prescribed to someone who's taking OxyContin legally and wants to come off it instead of increasing it? And what are your thoughts on that? And also, if you could talk about that fine line between dependency, addiction, and pain management, especially for people who have no history or any record in the New Jersey prescription drug monitoring program. Any comments on that? And then I think Director Rodriguez will go back to you for comment on that as well after Dr. Nelson.
So to answer the second question first, this is a very large point of contention between different perspectives of clinicians and others, whether or not chronic use of opioids leads to quote unquote addiction. Remember, addiction is more of a psychosocial construct involving loss of control and sort of your life sort of falling apart around you, including losing your home or your job or your spouse or something along those lines. So it's not simply, am I using medications in an uncontrollable way? It has to be associated with the entire wraparound of a psychosocial sort of self-destruction. And that's addiction. Of course, everybody on an opioid long-term is going to be dependent, right? Whether it's, heroin, fentanyl, oxycodone in the OxyContin pill, meaning when you stop taking the medication, you're going to have withdrawal syndrome and you're going to feel lousy, you're going to crave the drug and you're going to want to take more. So in a way, whether you're addicted and you have that wraparound or you're just dependent is somewhat irrelevant because you can't stop the medication. Right. And so in order to stop oxycodone or any opioid in a short, in an abrupt manner, you must be transitioned to something else. And of course, you can use another full agonist opioid like methadone, or you can switch to a partial agonist like buprenorphine. The problem in either case is it can't just be done in an uncontrolled fashion. You can't just give somebody the medication and say, here, take this. If they start on methadone without tapering the oxycodone, they're going to overdose. And if you start buprenorphine without tapering oxycodone, they're going to withdraw because of that partial agonist effect. It's a very hard thing to do. Switching from methadone to oxycodone is extremely difficult, not something that should be done by the uninitiated, and it's probably very hard to do as an outpatient on a telehealth platform. Not impossible, but you need a very compliant patient, social situation, and a doctor who's pretty familiar with doing it. Much easier with the short-acting opioids because you can more or less just say stop. In 6 or 8 or 12 hours, you're going to feel lousy. Here's when you take your buprenorphine. But the predictability with the long-acting opioids, whether it's oxycodone or methadone, is much more difficult. Hopefully that answers that from my perspective. And I forgot what the first question was already. I'm sorry. Angela, if you're still there.
Yes, I'm still here. Did you ask me to repeat the
first question?
Yeah, that was just that. I think you addressed it. It was really that fine line between addiction and pain management and accessing the PMP. So what that means and how that's helpful.
Yeah. I mean, I didn't cover the PMP, and I'll let Mr. Rodriguez do that. But I will say that the PMP is an invaluable tool for us in many situations, and I hope its ability to be useful is expanded continually.
Okay, great. And Director Rodriguez, do you want to touch on the PMP and how it continues to be a tool for prescribers and pharmacists?
Absolutely. I mean, the PMP, as I noted earlier, is, and I appreciate your, doctor, that you find an invaluable tool. We continue to hear that from prescribers, and pharmacists, but particularly prescribers. The PMP really is a tool to give prescribers more insight into the patient's business in itself, and part of the it's not prescriptive. It is there visualize the data.
I'm sorry, Paul. We're just having a really hard time hearing you. I don't know if we're having
I'm sorry.
a technical issue. Yeah.
That they're able to, especially with the enhancements, they're able to visualize the data in a useful format. Those alerts also provide useful insights. We hear from prescribers that they are able to learn about certain patterns of prescribing that they have not seen previously and prescriptions that are being provided by other prescribers. And in some cases, we're separate from the individual treatments of the patient. Prescribers are learning as they look at their own PMP data, which you're able to do, able to identify that there is prescriptions in your own name that you did not authorize, and prescribers are able to identify fraud in that manner as well.
All right, thank you. And I think this next question would be for Special Agent Gibson and for Sharon. I know Dr. Nelson talked about the recovery support when someone is identified as having had an overdose or addicted or dependent. But when your agents or officers come into contact with people, what diversion strategies are you utilizing, if any, for those people that you encounter?
Hi, this
and
is...
I guess, yes, go ahead.
Angela, are you referring to people that we encounter that are addicted or people that we arrest?
Well, you want to touch on both?
Well, I mean, here at DEA, we try to focus on a more international, larger scale distributor of drugs. So us encountering people with addictions, we don't necessarily encounter them too often. But when we do, obviously we note it, and usually at some point there's interaction with the family during the court proceedings, and we can at least let them know what we experienced. When it comes to how we affect arrests, once we know we're going to be in contact with somebody, we make sure that we have enough PPE ready, and that not only are my agents and diversion investigators and task force officers affixed with PPE, but we also put PPE on the person that we're arresting immediately after the handcuffs are placed on them, which has prevented my people from getting exposed positively to COVID. But yeah, we definitely work closely with our local police officers, and if there's any kind of help that we could forward to anybody that's addicted, we do, definitely. And plus, too, we work in the demand reduction arena a lot. We do a lot of different programs for outreach, and a lot of them are through you and your shop there, Angela. So we're definitely out there trying to get the word out.
No, absolutely. And I know together we've really been on the forefront of the education as well in that prevention side. But Sharon, I know you guys have the Helping Hands project. You want to speak?
Right.
We really
have two projects. One is the Operation Helping Hands, which continues to evolve and enlarge over time. We have Operation Helping Hands programs in all 21 counties at this point, both funded through state and federal funding. And the whole purpose there is to connect people either through a traditional arrest model, people who may be low-level purchasers, and offer them immediately on the spot an opportunity to seek care. And we have encouraged the local prosecutors' offices and law enforcement to work with peer recovery specialists and organizations to sustain that recovery over time. We also have another project which has been a little delayed by COVID in 5 of the most in need municipalities to basically do a 24/7 ability to connect people in need with care. So diversion in this definition is really getting people to care and, to use this as a juncture at which that's a possibility for them. So, we hope to continue to expand that. We will continue to seek out grant opportunities that will allow us to continue Operation Helping Hands and programs like that.
All right, great. Thanks for that information. Dr. Nelson, have you encountered any issues with your patients encountering pharmacies that limit the buprenorphine dosing, or with your patients not being able to get naloxone prescriptions covered by their insurance?
We really haven't had that problem. I think the big problem we sometimes face is with the payers and their, the specifics they have around what they're willing to cover in terms of film versus tab versus the dose max. Some have set a limitation of 16 milligrams, some have said 24 milligrams. There's not any, real clear guidance on a lot of these things. But in general, it hasn't been a big problem. The naloxone issue really is, again, one of being able to pay for it. Many of our patients that we care for don't have adequate insurance, and they have to pay out of pocket. And obviously, the one intramuscular version that costs several $1,000s is off the table. The one that we can prescribe for most people, or it could be, dispensed from a pharmacy directly, is, the $120 range, much more manageable. But even that's a fair amount of money for some. The one we give out, of course, is free, but we don't take care of most people in the state. And I don't know that all EDs are doing this, or all practices are doing this. It's a cost that would be nice to be able to put off on to a third party, so the patients didn't have to pay for it themselves.
Sure. Director Rodriguez or Sharon, is there anything you want to add to that? Any information? I know last year there was a free distribution of naloxone, but is there anything that you want to add to that about, limits and naloxone coverage?
I think we're hoping to participate in additional free distributions, and, hopefully insurers will cover when needed.
All right, great. So we have a question that goes to veterinarians. So I think this might be a question for DCA or DEA about what role veterinarians have in prescribing requirements that apply to veterinarians, also training that is required for veterinarians who are prescribing, and does it get reported to the PMP? I think the person who asked the question is being told different things within the community. So any information that you can share on prescribing to veterinarians? I know we've been hearing, especially during this time of stay at home and quarantine, about how many pets have been adopted and such. This is a really timely question as well.
This is Paul. I will say, so veterinarians have a CDS registration. The CDS registration does require PMP that you either have to register for the PMP as well. Veterinarians are exempt from the mandatory requirements. But that being said, we do hear there are a number of veterinarians who use the PMP regularly. It is helpful in identifying potential. We have heard from the veterinarians that it is helpful. It makes them feel more comfortable in identifying potential drug-seeking behavior and being able to ensure that drugs are not being diverted from the pets themselves. Unfortunately, the PMP is only set up to capture dispensations from pharmacies, so it's not going to capture drugs that are dispensed directly by the veterinarian themselves.
Great, thanks for that info, and Special Agent Gibson.
As far as the PMP, that those kinds of questions, I just got to leave it up to the state and have them interact with the veterinarians. But we have seen some patterns with veterinarians taking advantage of their ability to get certain medications such as tramadol. And we've also seen situations where we had people that are in the throes of addiction intentionally hurt animals to take them to the vet to get pain meds, which is a horrible scenario. So, but as far as the PMP goes, I agree with Paul and all of his sentiments that he said.
Great, thanks. And I think we'll just give you just the last question. You mentioned fentanyl, and we just had a question about, are we seeing an increase during this time, or do you anticipate there being an increase once the public health emergency ends of fentanyl? I know you mentioned a few different ways that things are coming into the country and issues caused by the pandemic. Is there anything you can share on fentanyl?
I did see that question, and I just wanted to make it clearer. The cocaine, the heroin, any kind of drug that we get has fentanyl in it. So we have to wait until after it is tested to know the exact amounts of how much fentanyl was in it. So if we are doing an operation and we think we're buying heroin, then we put into the lab as suspected heroin. But mostly all the product comes back with fentanyl in it. And I was just recently asked what's the most dangerous drug out there. And it could be anything that has fentanyl in it. And we have meth that they're using fentanyl, cocaine, heroin. So even those numbers that I put up, they all had fentanyl in it at some point. All the pills that we seize have fentanyl in it. We just recently did get kilo quantities of fentanyl, which is slightly unusual because usually it's placed into or mixed into the product that they're selling prior to us getting a hold of it. So it's always nice to get pure form of fentanyl in kilo form. And the money that these traffickers make on a kilo of fentanyl is just tremendous. So again, it's in everything that we seize.
All right, great. And I think we will end our panel discussion on that. So thank you so much again to all of our panelists. Thank you to all of you who have stayed on with us. I think we have over 300 of you still on. So thanks so much for that. We will continue to share information and resources with you through an email and a brief survey that you can complete. I appreciate you completing and giving us some feedback on this this learning activity. I again want to thank all of our panelists for sharing their expertise today. Thank you to Assistant Attorney General Sharon Joyce, Kelly Levy, and the NJ Cares team, and all of you participants for joining this conversation to knock out opioid abuse and address addiction in our communities and state. Information on upcoming webinars, we have something scheduled for September 24th. It's up on your screen in collaboration with NJ Cares and the Office of the Attorney General are available, along with resources and a copy of this presentation on the website knockoutopiatabuse.drugfreenj.org. Thank you again for committing to be part of the solution to address New Jersey's opioid crisis. And on behalf of Horizon Blue Cross Blue Shield of New Jersey Office of the Attorney General, NJ Cares, and the Partnership for a Drug-Free New Jersey, we wish you continued good health. Have a good afternoon, everyone, and be well.
Thank you.